Welcome to audience and welcome Dr. Sinha, welcome Dr. Devesh. Thanks for having us and to have a discussion on ulcerative colitis. It's a privilege for us to have you both today. So we at MSN Labs always strive to contribute to improved quality of life and ultimately society's greater good through our sustained efforts in developing and manufacturing safe, innovative, and affordable pharmaceuticals for elevation of life-threatening disease and to serve humanity. Our vision is not only to provide affordable medicine, but also to touch human life the first. We are MSN, serving the patient better today and tomorrow. We have established across India, USA, and Myanmar. We are the only company in India who bought tofacitinib for the first time, and that also in fraction of international prices. So, doctors, according to reports in India, around 60,000 of new patients are diagnosed in a year, in which 25 to 40% of patients remain non-responders to the conventional therapy. So for us, it's really important to understand the newer approach in ulcerative colitis, and it's a great opportunity and privilege for us to have you both who are well experienced in the treatment of ulcerative colitis. So I would be now giving Dr. Deves to share his screen and to talk about tofacitinib. And before that, I would be just giving a small introduction of Dr. Devesh. Dr. Devesh is Associate Professor at BHU Varanasi. Dr. Yadav has special interest in IBD, and in case of IBD clinic, he's in charge and department in the Department of Gastroenterology, IMS BHU Varanasi. He has credits in more than 50 plus publications in journals. And we have Dr. S.K. Sinha, who is professor in Department of Gastroenterology, PGI, Chandigarh. Dr. Sinha is editorial board member in Journal of Digestive Endoscopy. He has published more than 350 research papers in national and international journals. Dr. Sinha has thesis guided more than 80% of fellows. So welcome to you both, doctors. Thank you so much for joining and sharing your experience with MSN Labs. So Dr. Devesh, you can share your screen.
Good evening to everyone, and thank you for such a nice introduction. In brief, I will discuss the pathogenesis of ulcerative colitis with special reference to JAK-STAT pathway. I am going to share my slides. Just once. Is it visible?
Yes, sir. It's fine, I think.
I will discuss about the understanding the pathogenesis of ulcerative colitis and describe the relationship between the JAK-STAT signaling pathway and pathogenesis of ulcerative colitis. So first of all, a few lines about ulcerative colitis. Ulcerative colitis is an autoimmune relapsing remitting chronic disease of large intestine in which the lining of the colon becomes inflamed and develops tiny open ulcers. Ulcerative colitis patients has chronic inflammation of the large intestine, which further triggers the symptom of ulcerative colitis like recurrent diarrhea, pain abdomen, cramps, fatigue, weight loss, blood in stools, etc. Prevalence of ulcerative colitis is around 40 to 44 per 1 lakh people. So what are the factors which causes ulcerative colitis? Ulcerative colitis, the exact etiopathogenesis is not known. It is an idiopathic disease, but many theories have been proposed, like genetic factors, environmental factors, and immunological factors. There are three major factors involved in the pathogenesis of ulcerative colitis. Genetics. How do we know that ulcerative colitis is a genetic disease? Family history. It is seen that the chances of ulcerative colitis or relative risk of ulcerative colitis is around 8 to 10 times more in first degree relatives as compared to general population. Chances of getting disease is more in monozygotic twins as compared to other siblings. And this genetic susceptibility is more seen in Crohn's disease as compared to ulcerative colitis. And there are many susceptible genes responsible for this inflammatory bowel disease, especially ulcerative colitis. There are 163 loci for inflammatory bowel disease and 23 are specific for ulcerative colitis. It is a polygenic disease. Few important genes are autophagy gene like IRGM, P40 subunits of interleukin 12, interleukin 23, and interleukin 23 receptor gene, JAK2 and STAT3 gene. A brief about environmental factors. How do you know that environmental factors play a role in pathogenesis of ulcerative colitis? Hygiene hypothesis. We see that patients living in rural areas, living in farm, large families, in unhygienic conditions, or drink unpasteurized milk, they have more chances of getting ulcerative colitis later in the life as compared to others. Smoking, as we know that smoking is detrimental for Crohn's disease and it is protective for ulcerative colitis. Patients who have left smoking, persons who have left smoking are at high risk of developing ulcerative colitis. Third is non-steroidal anti-inflammatory drugs. NSAIDs can trigger flares in IBD and also can cause inflammatory bowel disease. Relationship with appendicitis. Persons with appendicitis are less likely to develop ulcerative colitis in later life. Vitamin D deficiency has also been said to be related with inflammatory bowel disease. Role of diet. So Western diet that is high in fat, low in fiber, or fast foods, or sweeteners or emulsifiers, these diets are risk factor for developing inflammatory bowel disease. Few studies have shown psychiatric illness to be associated with inflammatory bowel disease, and mainly depression and anxiety disorders are associated with IBD. And few studies have shown that if you are treating depression with antidepressant, then chances of getting IBD is less. Third is the immunobiology. I will discuss later about intestinal microbiota, intestinal immune system, epithelial barrier of the colon, antigen recognition, and immune cell homing to intestinal mucosa. So under physiological conditions, there is homeostasis between the commensal gut flora and epithelial cells that line the interior of the intestines, immune cells within the tissue. So in the intestinal lumen, there are many commensal bacteria, there are anti-inflammatory bacteria, and there are also pathogens. But the mucus layer, the epithelial layer, epithelium is a natural innate immunity so that these harmful bacteria does not enter the lamina propria or epithelium, and so there is balance and there is no or minimal inflammation in the colon in the homeostatic phase. But this homeostasis is disrupted in susceptible host, like those with genetics or other environmental factors in a specific environment like diet, antibiotics, anthropathogen, stress, and genetic factors, resulting in hyperactivation of Th1 and Th17 cells. There is increase in tight junction permeability, leading to entry of the antigens or bacteria into the epithelium, and that led to uncontrolled chronic inflammation. Th1 and Th17s are pro-inflammatory and Th2 is anti-inflammatory. So there is upregulation of the Th1 cells and Th17 cells and downregulation of Th2 cells. And these lead to chronic inflammation, that is ulcerative colitis. In this picture, you can see that there are many environmental triggers like smoking, stress, drugs, diet. In a genetically predisposed individual, this involves the dysfunctional response from innate and adaptive immune system. The multiple inflammatory cytokines are overexpressed. Amplification of the immune response leads to phenotype expression of the disease and tissue destruction and mediate dysfunctional cell-mediated interaction in innate and adaptive immune response. So if there is uh, disbalance between these uh, microbiota and harmful microbiota and useful microbiota, then that antigen or bacteria enters the epithelium, and dendritic cell works as antigen presenting cell, and after that macrophage is activated and many pro-inflammatory cytokines are released, leading to mucosal injury, that is ulcerative colitis. In this picture, you can see that there's disruption of, this is the overall pathogenesis of this ulcerative colitis. First, this is a disruption of tight junctions, and the mucus film covering the epithelial layer causes increased permeability of the intestinal epithelium, that is leaky gut, resulting in increased uptake of luminal antigens. And then circulating T cells bearing the integrin alpha 4 beta 7 bind to chronic endothelial cells of the microvasculature through the mucosal vascular adhesion molecule, that is MADCAM, whose expression is enhanced in the inflamed intestine, leading to increased entry of gut-specific T cells into the lamina propria. So there is T lymphocyte trafficking towards the lamina propria from the endothelial side. And there is upregulation of inflammatory chemokines such as CXCL1, CXCL3, and CXCL8, and leads to recruitment of circulating leukocytes, which perpetuates the cycle of the inflammation. So first of all, there is disruption of the epithelium and mucus layer, entry of the antigen, and that is activation of the dendritic cell, and then activation of the Th1 and Th17 cells, and release of many cytokines, pro-inflammatory cytokines like interleukin 13, interleukin 12, interleukin 23, interleukin 17, and TNF alpha. These leads to these start the inflammation, and the inflammation is progressed, and from the endothelial sites many leukocytes are being brought towards the lamina propria by alpha 4 beta 7 through a MADCAM receptors, leading to chronic inflammation. So this was in brief the pathogenesis of ulcerative colitis, mainly genetic factors, environmental factors, and immunity, both innate and adaptive immunity. Now I will discuss in brief about the JAK-STAT pathway. What is JAK-STAT pathway? JAK-STAT is Janus kinase, and STAT is signal transducer and activator of transcription. This signaling pathway transmits information from chemical signals outside the cells, which causes DNA transcription activity in the cells. So JAK-STAT basically connects outside the cell to the inside the cell, so that transcription occurs from the DNA. Transcription is from DNA to RNA. JAK-STAT system is major signaling alternative to the second messenger system. There are three components. One is receptor, that is on the cell. Second is Janus kinase, and third is STAT, that is signal transducer and activator of transcription. Janus kinase, which have tyrosine kinase activity, binds through some cell surface cytokine receptors, and the binding of the ligand to the receptor triggers activation of JAK. With increased kinase activity, they phosphorylate tyrosine residue on the receptor STATs, possessing SS2 domain. And activated STAT dimers accumulate in the cell nucleus and activate transcription of their target genes. STATs may also be tyrosine phosphorylated directly to the by the receptor tyrosine kinases, such as epidermal growth factor receptor, as well as by non-receptor tyrosine kinases. I will discuss this in next figure. So this is the first is the cytokine receptor. The red one is ligand and the green one is ligand binding sites. And we can see that when the ligand is attached to the ligand binding sites, they activate JAK and ATP is converted into ADP. And then JAK is dimerized. There is dimerization and phosphorylation of tyrosines. So two JAK are combined, that is dimerization, and then there is activation of the tyrosines. And then there is phosphorylation of additional tyrosine residues on the JAK. This is the same. This is EPO is erythropoietin receptor. There is activation of JAK and dimerization. Then the SS2 domain of the STAT that combine to the JAK and dimerization of STAT occurs. And after dimerization and phosphorylation, that STAT then enters into the nucleus, binds to the DNA, and then starts the or activates the transcription to produce the proteins. This is how the pathway works. I already discussed. Activated JAK, then phosphorylation of tyrosine residues, and then bind signal transduction and activation of transcription, and then STAT is phosphorylated by JAK and dimerization of the STAT, and that then translocation to the nucleus and gene transcription starts. So basically, this is the JAK STAT pathway, and it is very important in pathogenesis of ulcerative colitis and other diseases because through this signaling pathway, many cytokines and interleukins are released. And if you will block this pathway, JAK STAT pathway, you can check the inflammation by cytokines and interleukins and can be used in many diseases, many autoimmune diseases. It's a regulatory molecule that binds to receptors linked to JAK, like interferon gamma. Effect is activation of macrophages. Interferon alpha and interferon beta, it is a cytokine and induces antiviral state to limit viral infection. Interleukin 2, this is cytokine, promotes lymphocyte proliferation in a specific immune response. Growth hormone, this is postnatal growth stimulation, metabolic effects. Leptin, this is regulation of body weight. So not only the inflammatory cytokines and interleukins, other chemicals or like hormones and leptins are also produced by the activation of JAK STAT pathway. So if we check the JAK STAT pathway, we can check the inflammation and can be used in many autoimmune diseases. Thank you.
Thank you, Dr. Devesh, for the wonderful talk. I would be requesting Dr. Sinha to share his screen as well.
Okay, just give me a minute.
And audience, meanwhile, if you have any question, you can put that in your chat box. Dr. Devesh and Dr. Sinha would be taking up all the questions after their once they present their slides.
My slides are visual, Dr. Levina. Hello. Yes, my slides are Visible?
Yes, visible, sir. You can continue.
Oh. So I'm going to discuss about the practical aspect of it. Theoretical part, Dr. Yadav has discussed. So I'm going to talk about how to leverage the JAK inhibitors to tame the inflammation in ulcerative colitis. So I will not be touching upon anything on the Crohn's disease, although the two are very related condition, for the simple fact because in India we have only tofacitinib available. Its predominant role is in ulcerative colitis. It has surprisingly shown much less efficacy in Crohn's disease, and licensing is for ulcerative colitis. So I will be talking only on ulcerative colitis. So that if you see the treatment goals of ulcerative colitis, traditionally over the years and decades, we have been concentrating on control of symptoms in this mainly with either steroid or 5-aminosalicylic acid. Subsequently, as the science progressed, our understanding of the disease progressed, we started talking of remission induction that resulted in improvement of quality of life and possibly reduction in the complication related to inflammation. However, with the availability of better drugs and better understanding of the disease, the treatment goals change over a period of time in the era of biologicals and immunomodulators. We started talking about the mucosal healing, which can be histological healing, or it can be endoscopic healing, or we started talking about deep remission, which is a dream destination, which is achievable currently only for some, but most importantly, it reduces the risk of complication, and it not only that, it also changes the course of the disease. So emerged the concept of disease modifying anti-IBD drugs. So that was with the beginning of era of immunomodulators and biologics. So we are going to see closely for it. So if you see with conventional treatment, there is improvement, change in work impairment, quality of life. Work impairment basically means that patient is doing well, but with biologics, that is much more effective, so that work impairment goes down. So if you see all those figures with biologics, that has gone down. So biologics are working, but is it working for everybody? So possibly no. And if you see that it works only a subset of patients, possibly less than half of the patients, and ultimately if we talk over a period of time, some sort of resistance develop or loss of efficacy happens, and by the end of 2 years or 3 years, possibly only 1/3 of the patients are responding to these drugs. So there is much space for improvement, and that's why we needed more drugs, more armamentarium. So we needed to expand our armamentarium for the treatment of ulcerative colitis and IBD. So over the years, what has happened in last few years, that a new class of drugs have come into treatment, which is called JAK inhibitors. So if we inhibit, JAK stands for Janus kinase, and there are 3 Janus kinase, JAK 1, 2, 3, and there is 1 tyrosine kinase, and then there are 7 transcriptional activator which lies across the membrane. So these molecules tend to modifies this pathway, which Dr. Yadav has already discussed. So I will not go into detail of that. But most importantly, if you see, if you inhibit JAK1, these mediators will go down. JAK2, other mediators will go down. JAK3, different, and tyrosine kinase, there are different ones. So there will be different. This is important to understand because we are going to have lots of JAK inhibitors in coming future, and they will differ because of different degree of inhibition of different JAK isotypes. So already we have at least pan kinase inhibitor, which is tofacitinib, which is we are going to talk today. Then we have filgotinib, which is available to some of us in India as a part of trial, including our center. And then we have upadacitinib, which is also very potential, very strongly coming molecule. So if we see, this is dominantly, this is pan kinase inhibitor. So JAK 1, 2, 3 and tyrosine kinase all are inhibited. of variable degree, but filgotinib is mainly JAK1 inhibitor, and upadacitinib also is dominantly JAK1 inhibitor. So many of the adverse effect of these drugs is related to basically the metabolic pathway or the mechanism of action. So possibly the risk of thromboembolism, which is seen with tofacitinib, is possibly little less with filgotinib and upadacitinib. So over a period of time, we will get to know this is because of mechanism of action. So all the three drugs are basically oral drugs and rapidly absorbed from the GIT, and has a half-life ranging from 3 to 6 hours, and has a good bioavailability, and most of them are metabolized in the liver, so and excreted in the urine as an active metabolite or inactive metabolite. This is going to have bearing on our clinical decisions, so that's why I'm highlighting you here. So these molecules arrived. So what we are going to see, what is the evidence for use of these drugs. So this is landmark Octave trial, which formed the basis for licensing of tofacitinib, approval of tofacitinib for use in ulcerative colitis by US FDA. And there are 3 trials, Octave 1, 2, and then Octave Sustain. And then I'm going to talk about the 4th trial. So this showed that it is better if it has a better efficacy compared to placebo or no treatment or the conventional treatment. So there is good efficacy, but you should be noting that even at the best, we have efficacy rate of only 40%. So possibly less than half of the patient will have complete response, which is our target. So if you talk of mucosal healing, possibly the figures are still less than 50%, but it much better than controls, conventional treatment. And if you see, I will be later on showing comparison with the other biologics. So these patients respond. So this was very gratifying. So conclusion was simple. Among patients with moderate to severe active ulcerative colitis, therapy with tofacitinib at a dose of 10 mg twice daily was more effective than placebo for induction of remission and mucosal healing. And maintenance therapy at the dose of 5 or 10 mg twice daily was more effective than placebo for maintenance of remission. So it is not only effective for induction of remission, this is also effective for maintenance of remission. Recently, what happened that long-term data has emerged up to 7 years. So what happens in many of the biologic drugs, there is loss of efficacy over a period of time. So body adapts to that, the metabolic pathways develop escape route, and the inflammation comes back. But fortunately for us, and fortunately for the patients, that this drug seem to remain effective even during 7 years of use, continuous use. So tofacitinib demonstrated consistent efficacy up to 7 years, and data collected up to month 36 support long-term efficacy beyond 52 weeks of maintenance therapy. So this is very, very important, that there is no loss of efficacy. So if you see the guidelines, that was the evidence from trials. So ultimately multiple trials come, and that gets translated into guideline. So this is one of the UK guideline, nice guideline I have quoted here. So for remission induction, we use in the dose of 10 mg twice daily in both TNF naive patient as well as TNF exposed patient. But for the maintenance purposes, that is after 8 weeks, the dose becomes 5 mg twice daily for TNF naive patient, whereas those who have prior exposure of anti-TNF drugs like infliximab, adalimumab, they will continue to be on 10 mg twice daily. However, those patients who go on 5 mg twice daily, if there is loss of response or a relapse happen, then 10 mg twice daily dose can be used. There are a specific situation where we use even 10 mg thrice daily, which I am going to discuss subsequently, but that is beyond licensing. There is no licensing for dose more than 20 mg as of now. So the drug is metabolized by hepatic cytochrome P450 system, mainly CYP3A4. So if you remember, and then eliminated in renal through the kidney, almost 30%. So automatically you will get to understand that it will have interaction with hepatic cytochrome P450 inhibitors like ketoconazole and fluconazole, and cytochrome P450 inducers like rifampicin, which will decrease the efficacy, and this will augment the efficacy, or augment the toxicity. Tofacitinib has a half-life of 3 hours, but in the international market there is a XR preparation available which has a long half-life of 6 hours. But the drug dose needs to be modified in moderate to severe renal impairment, or if there is hepatic impairment, and the dose should be reduced by half, 50%. So that should be remembered. So there are lots of variables which were studied in the trial. So age, body weight, then creatinine clearance, gender, ASEAN versus non-ASEAN status, and it was found that barring the renal function, other factors don't affect the serum level, and the drug level remains within the therapeutic range. So that doesn't require. So only thing which requires dose correction is possibly the kidney function and liver function, as I have discussed already. So there are lots of talk among the people about that obese people or overweight people tends to respond less well with tofacitinib, but when the data was analyzed, large amount of data was analyzed, so this is the result came. So there is no difference with respect to BMI. So we don't have to bother that we will have to give this drug based on the body weight. So that is important. So one more important point, that the guideline says that patients' maintenance dose of 10 milligram twice daily should not be used in those patients who have risk of thromboembolism, high risk of thromboembolism, in the form of prior history of pulmonary thromboembolism or any thromboembolism, patient who have undergone recent major surgery, are embolized, use of combined hormonal contraceptive, inherited regulator coagulation disorder, malignancy, and other VT risk factors. So sometimes, obviously, like you saw earlier, that efficacy in terms of IBD and biologics we talk, the efficacy is in terms of 30, 40, 50, or 60%. So there is a good subset of patients who don't respond to these molecules. So when they say this patient is not going to respond, so we have to give a trial up to 16 weeks. I mean, if somebody is not responding during that period, we say this is primary non-response, and we further don't use this drug further in those patients. Most importantly, as of licensing conditions, this drug is currently not recommended for use with cyclosporin, azathioprine, tacrolimus, infliximab, etanercept, rituximab, and adalimumab. So these things are likely to change rapidly over with the coming time, because combination therapy is on the horizon, but because of evidence reasons, these are not recommended. And as I told you earlier, there are already a small series and case reports are appearing, use of tofacitinib along with the other biologics and immunosuppressive drugs like cyclosporin or different biologic drugs. So we have to go through the cycle that how to start the drug. Before starting, we have to look for latent TB that we have learned in the era of infliximab, that either we do chest CT scan, or we do Mantoux test, or we do IGRA. If that is positive, then patient will require antitubercular treatment beforehand, before starting tofacitinib. Baseline complete blood count is done, and that has to be repeated at 1 to 2 month interval, and subsequently every 3 monthly. Then this drug is known to cause dyslipidemia, so it should be done at baseline, and subsequently should be repeated approximately 2 months, and liver function also should be monitored. This drug should not be used if the hemoglobin level is less than 9, if there is absolute lymphocyte count less than 500 and absolute neutrophil count less than 1000. So these contraindications should be checked, and then the patient should be prescribed this drug. Side effects are very common. I will say reasonably common. 1/4 to 1/3 of the patients will develop some sort of side effect, but most of these side effects are trivial, doesn't require discontinuation of treatment, except for a very few patients where, like herpes zoster, where a temporary cessation of the treatment will be required. So infections are the most important, but here we have shown direct comparison. In the IBD biologic world, direct comparisons are very few available, and out of all the biologics, ustekinumab is possibly has a least risk of infection, and if you see comparison, this drug is comparable to ustekinumab. So infection risk is there, but of all the biologics, the risk is minimal. So the pattern of infection is also not different. So pattern of infection virtually same. So this is bacterial infection, then viral infection, and the fungal infection. So this is almost similar in tofacitinib. So like biologics, this also increases the risk of infection. The pattern of infection is also very similar. And this is the frequency of adverse drug reaction. For some peculiar reasons, the ulcerative colitis patients are more prone for GI side effects because the GI is already involved compared to rheumatoid arthritis patients. So this is an editorial. They talked about the adverse drug reaction and safety of the drug. So they, after reviewing huge amount of data, they came out with the conclusion that in emerging real world evidence confirms the acceptable safety profile of TOFA, and it is consistent with the safety profile observed during the Octave clinical program. So trial and field condition, it is performing same. So there has been lots of talk about the risk of thromboembolism with TOFA. We know that ulcerative colitis per se is a prothrombotic condition, and there is risk of venous thromboembolism, and that increases marginally with the use of biologics like anti-TNF alpha drugs. The same happens with tofacitinib also, and the risk is comparable to anti-TNF alpha drugs, not higher. So sometimes it happens that situation is different in trials and completely different in real world situation. But if we see the efficacy part, even in the real world situation, lots of trials, 6 trials, meta-analysis. So if results were comparable, what was seen in the trials, so the same actually, the remission achieved in figures comparable to the trial condition. So it was not different, and it also showed the safety part. So as I told you earlier, there in the field of biologics in IBD, very few direct comparisons are available. So this is one trial I have quoted you here. This is tofacitinib versus ustekinumab. So the two drugs were very comparable in efficacy and the side effect profile wise, which I have shown you earlier. But when direct comparisons are not available, we use stats for different comparison, and the best model for that is network analysis. So what network analysis, in contrast to meta-analysis, does, it grades the efficacy. So here, if you see, the JAK inhibitors are virtually on the top of the list. So they have very good efficacy and safety profile compared to other biologicals. So they are to be watched. Again, another network analysis, very, very recent one. So if you see again, these are all JAK inhibitors which are on the top of the list, and all other biologicals prior infliximab, adalimumab, they are much below that. So they are the drug to be watched, drug to be preferred, and that they have the better efficacy, and the side effect profile wise also they are comparable. So among the conventional biologics, vedolizumab is possibly the best performing, and in the JAK inhibitor, upadacitinib is best, but sort of that we can use tofacitinib. So we have seen that this is indicated in moderate to severe active ulcerative colitis, but as the time is passing, we are learning more evidence coming. So indications of usage are expanding. So it has been like extraintestinal manifestation. We know that similar metabolic and inflammatory pathway work there. So it has been found that this is also effective in many of the extraintestinal manifestations of IBD. And that controls, none of them worsen. So this is the data which is showing that the any history of AI extraintestinal manifestation is not a contraindication for use of tofacitinib, and most of these conditions will actually improve with use of tofacitinib. Then initially the drug was not used in acute severe colitis. That regime that was exclusive area of use of steroid and infliximab. So now slowly people are using, and the data is coming here. 6 small trials I have quoted, which is quoted in a meta-analysis from our department. So it showed that it is efficacious and it can be useful drug. Subsequently, we have a very interesting trial which has come up, although it is retrospective in nature. So what they have shown that 10 milligram thrice daily, not the 20 milligram dose, 30 milligram dose, which is not the licensed dose, but which has a very good efficacy along with steroid in this situation. So this is to be watched and possibly become a standard of care in coming days. So here the dosage is different, that one should always remember that in acute severe ulcerative colitis, along with steroid, we can be using even 30 milligram dose of tofacitinib. So perioperative player, earlier it was taken as contraindication for use of tofacitinib, but this one trial, they analyzed their data, retrospective in nature, and they said that it is slightly higher risk of venous thromboembolism, but not a very dangerous drug, and it can be used if required. So only thing that in such a situation, it is mandatory to use PT prophylaxis or thromboembolism prophylaxis, which anyway is done in IBD patients who have active IBD. So now, like we have learned with hepatitis C, we have learned in tuberculosis therapy that combination works better. So IBD is no different. People are moving to combination therapy. And if you see, earlier I had shown that efficacy rate is somewhere 30 to 50%. So with combination, the efficacy rate is much higher. There is one trial where they have used combination of vedolizumab with tofacitinib, and the efficacy rate was 60%, which is pretty high figure, I will say. And this is endoscopic response. So this is a very good criteria they have used for assessment of response, but this is limited data, so we cannot make generalization. There are certain issues which need to be understand, and whatever answer is available, I will try to show you. So vaccines, we cannot give live vaccines to the patients who are taking tofacitinib because of obvious reasons. So, but killed vaccine and protein vaccines can be safely given, and for live vaccine will remain contraindicated during use and up to 4 to 6 weeks after stopping the tofacitinib. Then with certain drugs, particularly like infliximab, we had seen that retreatment is difficult proposition because of antibody formation, loss of efficacy. But this drug has been found to maintain efficacy during retreatment, and there is only minimum loss of efficacy. De-escalation of therapy. So most patients, when we come down from 10 milligram twice daily to 5 milligram twice daily, they tend to maintain remission. And if there is any issue, then we can always go back to 10 milligram twice daily, but only the risk of thromboembolism will be marginally higher. Whether this drug is cost effective, this drug is available at a cheaper cost in India, But even in Germany, where which is a typical Western market, there this drug has been shown to be the cost effective and cheaper in the long run compared to anti-TNF alpha drugs. So safety in pregnancy, this drug safety class is not assigned so far. So data is not available, but the current recommendation says that contraception should be used during treatment and up to 6 weeks after the last dose of tofacitinib. In animal studies, there is some evidence of teratogenicity with very high dose at a level which is not used in human beings. Limited human data available in which it has not caused teratogenicity. So possibly it is going to be proved to be safe. So I will summarize by saying JAK inhibitor is a relatively new class of drug in the treatment of idiopathic ulcerative colitis. Tofacitinib has shown good efficacy and safety profile in treatment of moderate to severe IUC, and it is also likely to be used in acute severe ulcerative colitis. Tofacitinib is particularly useful in the treatment of the patients who are exposed to anti-TNF alpha drugs but have developed resistance or loss of efficacy. The indication of use is increasing gradually. There are multiple new drugs of this class are on horizon and which are almost certain they are going to come in the armamentarium of treatment of IBD. Thank you all for patient hearing.
So thank you so much for wonderful session, sir. I must say that was a great learning platform for each one of us. So we have received few questions from the audience. So I would be just sharing those questions with you both. So first question is, for acute severe ulcerative colitis, would you prefer an oral drug or IV drug?
Okay, I take this question. So if you remember that when cyclosporin was used, so initial phase everybody was using IV, but subsequently it was shown that oral cyclosporin has similar efficacy, maybe even better efficacy compared to IV cyclosporin. So that answers your question that severity doesn't determine that you need to use oral drug or IV drug. And tofacitinib or the class of JAK inhibitors, they are oral drugs. So it has to be used orally because IV preparations are not available. Only the dose is different, which I have shown you that in acute severe ulcerative colitis, people have gone to 30 milligram per day, and that is clearly superior to 10 or 20 milligram per day.
Right, sir. Thank you for your answer, sir. The next question is, can it be used along with mesalamine?
Hello.
Hello, yeah, Dr. Devesh.
Sir is not audible.
I think he's facing some network issue.
Okay. I can reply it. When we use biological drug, we usually don't use mesalamine along with biological drugs. Biological drug alone is sufficient for induction and maintenance of remission. But if you want to use mesalamine along with tofacitinib, you may use because there are many anti-inflammatory and anti-cancer effect of mesalamine. Basically, patients using long-term mesalamine are less likely to develop colonic carcinoma in future. So there is no robust data on this that you should combine or not, but it's the physician's decision to combine mesalamine with tofacitinib.
Yeah. Dr. Sinha, if you want to add something on this or your view.
Dr. Yadav has answered very clearly that many of the guidelines says that that can be discontinued, and if not discontinued, we can use at the maintenance dose. So one has to remember that dose of mesalamine in active ulcerative colitis is different from maintenance dose. So maintenance, when we talk of maintenance dose, this is somewhere around 2 to 2.4 gram per day. Whereas in active ulcerative colitis, in mesalamine, we will be using 3.6 to 4.8 grams per day. So we use maintenance. If at all used, it is used in maintenance dose. Western blood world, most of the people tend to stop mesalamine. But here in PGI, we are, as a policy, it is our policy to continue mesalamine, despite patient being on biologics, either it is infliximab, adalimumab, or tofacitinib.
Okay, sir. Great. And next question is, when do you use tofacitinib, like placement of molecule in the therapy, in the algorithm?
So as of now, we are routinely using those patients. There are several of our patients who are exposed to biologic in the form of use of infliximab and adalimumab. They have had loss of efficacy or primary non-response, what we call primary non-response, which I talked even in with tofacitinib. So there tofacitinib is clearly we are using upfront, we are using in those patients. Even in other patients with mild to moderate colitis, and we are using, particularly who are not doing well with conventional therapy. Conventional therapy means controlling the disease with steroid, then tapering the steroid over a period of several weeks, and then continuing mesalamine. If the patient is not doing well with that type of therapy, then we go for tofacitinib, rather than going for infliximab or adalimumab, which we earlier used to do.
Yes, thank you. Thank you for great answer, sir. We have one question from Dr. Ranjit Singh, that what is the doses of tofacitinib in ulcerative colitis?
I showed in my talk, probably he might have joined late. So for active disease for up to 8 weeks, we have to use 10 milligram twice daily, and the dose is same for whether the patient has received earlier infliximab or adalimumab or not. So TNF alpha naive patient or exposed patients, the dose is same. But when it comes to maintenance, that phase starts after 8 weeks. So for TNF alpha naive patient, it should be 5 milligram twice daily. And those who are exposed to TNF alpha, they will continue to be on 10 milligram twice daily. But those who are put on 5 milligram twice daily, if they have loss of efficacy, relapse, or suboptimal response, they can always be shifted to 10 milligram twice daily. But there is caveat that they should not be high risk candidates for venous thromboembolism in the form of congestive cardiac failure, recent MI, stroke, history of embolization, and those things. They will require prophylaxis for that if it is used in that situation, 10 milligram twice daily. Or one more thing, that not a licensed thing, but if somebody uses in the setting of acute severe ulcerative colitis, one can go up to 30 milligram daily, that is 10 milligram thrice daily.
Okay. So, sir, actually adding to this, there was one doctor's question that he has heard about risk of thrombosis and all other risk, which is, which is along with tofacitinib. So, like how you manage or monitor patients and how you manage this side effects or risk of the molecule.
I mentioned earlier also that I have seen many centers in India. They don't routinely use venous thromboembolism prophylaxis in active IBD. But if you see international guideline, almost all guidelines, they say that if any patient of ulcerative colitis requires admission, meaning there has active disease, the patient will require prophylaxis at least till the time disease is controlled, and maybe 3 to 6 months beyond that. So we changed after our practice and started using prophylaxis in this subset of patients several years back. But still not all the centers in India are doing that, but it makes a sense. So by default, it means that anybody who has got moderate to severe ulcerative colitis and is in hospital environment possibly will require prophylaxis. So that will take care of the increased risk. but the risk of venous thromboembolism per se is there in ulcerative colitis patients. And so that should be kept in mind. And you do treat with whatever means one wants to treat, either anti-TNF alpha, either adalimumab, either infliximab, or even vedolizumab. The risk of venous thromboembolism is going to stay there, and the risk is not inappropriately higher for tofacitinib only.
Great input, sir. And Dr. Yadav, if you want to add something on this.
No, I think sir has nicely covered all the things about tofacitinib, and it's a wonder drug because I think it is cheaper as compared to other biologics, and it's not parenteral. It's taken orally, and compliance to this drug is very nice to the patients.
Just a last question, sir. We are just keep receiving questions from doctors. So just last question is, can it be used before using biologicals once first line of therapy failed?
Definitely. No doubt on that. So
Okay.
that's why in the dosing schedule I showed that TNF exposed, because TNF is available in the international market for several years, much before tofacitinib. So we have lots of patients who have received adalimumab and infliximab. So that's why that the doses are different. For induction of remission, the doses are same, but for maintenance, those who are exposed to anti-TNF, they will continue on the induction dose, that is 10 mg twice daily. Those who are not exposed to anti-TNF, they will come down to 5 mg twice daily. So that is the difference one should always remember.
So it was great with you both, sir. You have given a great insight on management of ulcerative colitis, and I'm sure that this is going to help a lot of HCPs as well to solve their queries which they were having on this newer approach, which is tofacitinib and ulcerative colitis. But it was great to have you both. So thank you so much for joining and getting associated with MSN Labs. It was our privilege to have you both, and we are looking forward to be associated with you in future as well, sir. Thank you so much.
Thank you.
Thank you, sir.
Thank you.
Bye. Good.
Thank you.